We'll back to Professor Ebtisam Ba, and we are looking forward to her talk about hyperprolactinemia management. Thank you.
Hello once again. This is my disclosure of relation. And this is the objective. After the introduction, we'll talk about the possible causes, the diagnostic approach, and treatment option, and some of the unresolved issues. And I will be a little bit faster for the sake of time. So hyperprolactinemia is an elevation of the prolactin hormone, which is secreted from the anterior pituitary gland. And hyperprolactinemia is a common endocrine disorder we see commonly in the clinic that can reach up to 17% of women in the reproductive age. We have to remember that not all hyperprolactinemia is due to prolactinoma, and there are many causes for hyperprolactinemia that include physiological causes, as you can see here, that include even the stress of the venous puncture, the pain, and many more, sleep, exercise, and stress, and so on. And we have pathological causes, list of pathological causes that varies from the hypothalamic pituitary disorders, tumors, hypophysitis, empty sella, hypothyroidism, polycystic ovary disease, ectopic prolactin production, hepatic and renal impairments, head injury, and post-ictal, and so on. And we have also a list of drugs that we are going to discuss that may result in hyperprolactinemia. And I need to remind you that almost half of the cases of hyperprolactinemia, the underlying cause is not known or idiopathic. This is a list of drugs that may result in hyperprolactinemia, and some of them are really common in our practice that include hypertension treatment, antidepressant, antipsychotics, including also the oral contraceptive pill, H2 receptor blockade, narcotics, amphetamine. And actually, drug-induced hyperprolactinemia is the most common cause of non-pathological hyperprolactinemia. And usually the level of prolactin is not severely elevated. Usually it's mild to moderate elevation. In data collection from United Arab Emirates in the largest tertiary center to look for the causes and the commonest causes of hyperprolactinemia, they concluded that the most common endocrine cause is prolactinoma, followed by polycystic ovary disease, while the most common cause of non-endocrine hyperprolactinemia is drug-induced. And I think this coincides with what all of us see in our clinics. Prolactinoma are the most frequent endocrine cause of chronic prolactinemia, pathological cause of prolactinemia, and they are benign tumor in most of the cases, in up to 40% of pituitary tumors. Women usually present earlier, and in 90% of the women, they usually present at the stage of microprolactinoma, while in men, they present later because of lack of symptom, and usually 60% of them, they present with macroprolactinoma. The progression rate from micro to macroprolactinoma is really up to 7%, so it's not very high. So what is the clinical feature of hyperprolactinemia? As I mentioned, female usually they present earlier with symptoms that may include galactorrhea, whether unilateral, bilateral, expressible, spontaneous, or intermittent, menstrual irregularities that may vary from amenorrhea to oligomenorrhea, and infertility and ovulation, and hirsutism. And it's very important to note that the severity of symptom is linked to the severity of prolactin elevation. They may present also with mass effect, with headache and visual field defect, in addition to osteoporosis, which is linked to the duration and severity of hypogonadism. In men, they present later with some of the symptoms that may include impotence, oligospermia, gynecomastia, and mass effect as well. And as I mentioned, they may present later than women, and rarely they may present with galactorrhea. Any patient with suspected pituitary tumor, you should always be examined for visual field, and usually they have bilateral temporal hemanopia, usually done by confrontation visual field and confirmed by automated perimetry testing. And as you know, as the pituitary tumor grows upward outside the cella, they presses on the optic chiasma, resulting in the visual field defect. However, the tumor also may expand laterally, compressing on the cranial nerves, so they may present again with ptosis and signs of third nerve palsy, as you see in this patient. So how to approach patient with hyperprolactinemia? The evaluation is usually aimed at excluding physiological, pharmacological, or other secondary causes of hyperprolactinemia. Let us start with the serum prolactin. One important thing before we discuss, we have to note that prolactin usually is released in a pulsatile manner, and many times we need to do the test more than one time. And sometimes you need to ask the patient to rest for 30 minutes before drawing the blood sample, as we mentioned that one of the causes of hyperprolactinemia is stress-related. Normal level in women below 25 and in men below 20. And in pregnancy, there is a progressive rise of serum prolactin that may reach up to 500 at the last trimester. And prolactin level usually normalizes within 6 months after delivery in a nursing mother and within weeks in non-nursing mother. So that's why it's not recommended to check serum prolactin during pregnancy. The definition of severity of hyperprolactinemia, as you have shown here, the marked prolactinemia is level above 200 nanogram, and usually the severity linked to the underlying pathology. And usually the higher the level is, the more likely is the diagnosis of hyperprolactinemia. And as you can see here, the higher the level, usually if it is severe, indicates prolactinomas, and even the higher the level, if it goes to 1,000, it also correlates linearly with the size of the tumor and may indicate giant prolactinoma. Any levels between mild to moderate could be still a non-functioning pituitary adenoma or any other causes like drug-related or physiological and so on. Both false positive and false negative results may occur when we measure serum prolactin, and this is very important, we have to keep in mind. It may be falsely elevated by aggregation from circulating prolactin, which is biologically inactive. Usually the patient has no symptoms and they have high prolactin, and this is what we call macroprolactin or big prolactin. It is common and it can occur in up to 40% of patients presenting with hyperprolactinemia. So macroprolactin is an overlooked reason for hyperprolactinemia, and if suspected, then the sample should be subjected to polyethylene glycol precipitation before assessment and before making the diagnosis of hyperprolactinemia. This term of macroprolactin should not be confused by macroprolactinoma. Also, we may have a falsely lowered serum prolactin, especially with levels really very high, like above 1,000 and giant prolactinoma, and this is due to essa artifact, and this is what we call the hook effect. The hook effect should always be considered, especially if the patient presents with giant tumor, pituitary tumor, with a lower level of prolactin, mild to moderate, which does not correlate with the size of the tumor. An overlooked hook effect may lead to incorrect diagnosis and predisposing the patient to surgical procedure, while the diagnosis or the response may be good with medical treatment. So actually the test is considered as antigen-antibody reaction, where the antigen is the prolactin and the antibody is the reagent. So if you have an excess of each one of them, that will interfere with the assay. And this is exactly what happens in the hook effect. You have too much of prolactin that may interfere with the assay, resulting in a falsely lower results. And this is actually may occur in up to 14% of patients with hyperprolactinemia. So the hook effect always sometimes misdiagnosed as non-functioning pituitary tumor, subjecting the patient unnecessarily to surgery. So when you suspect, you should do dilution of the sample, 1 in 10, 1 in 20, or even 1 in 100 to make sure of the diagnosis. And as we have heard today morning, and this is a key in endocrinology, don't proceed with a radiological study before you confirm the hormonal dysfunction, because that will result in a lot of incidental findings, and in pituitary, it may result in 10% of incidentaloma, which may complicate the matter. You should always investigate the patient for other causes of hyperprolactinemia that we have mentioned, that include also pregnancy for people in reproductive age, and rule out medications, and also assess other pituitary function if the tumor is big. Then followed by the radiological imaging with CT or MRI, microadenoma if a tumor is less than 1 centimeter, macroadenoma is defined if the tumor is more than 1 centimeter and extend beyond the cella. This is a case with microadenoma, as you can see, and this is another case, MRI, with giant tumor that fungates outside the cella. And this is a tumor that elevates the optic chiasma. So I'll just summarize here the approach to diagnosis and follow-up. If you have a patient with high prolactin, the first thing is you should rule out secondary causes. Productive age, you rule out pregnancy, do TFT, thyroid function test. If the patient is hypothyroid, treat and then recheck serum prolactin, check renal function, and check also for medication. If the prolactin is still elevated and the patient has they have no clinical symptoms, then you should keep in mind the macroprolactinemia that we have discussed. However, some author also suggest to screen all patients with hyperprolactinemia for macroprolactin to avoid this confusion. So if you suspect, then you do the polyethylene glycol precipitation, as we mentioned, and if it is negative, and this is true hyperprolactinemia, you should measure it again after 30 minutes of rest. And if it is high, then this is a true hyperprolactinemia, and the patient is asymptomatic. And if the patient is also symptomatic and have high prolactin level, then again, this is a pathological hyperprolactinemia. So the next step here, after you confirm this, then you do pituitary MRI. If the MRI is normal, then this is, or patient has microadenoma, then this is, sorry, if the pituitary MRI is normal, then this is idiopathic hyperprolactinemia. And if it is idiopathic hyperprolactinemia and the patient has microadenoma and the patient is asymptomatic, then you don't need to treat, you just only follow with serum prolactin. However, if the patient has microadenoma and symptomatic, or they have macroadenoma, then probably they will require treatment. The objective of treatment is to restore fertility and gonadal function and to prevent osteoporosis and also reduce the tumor size. So treatment of non-tumoral hyperprolactinemia depends on the cause. If it is medication related, then probably discontinue the medication if possible. If it is hypothyroid, then treat hypothyroidism. As I mentioned, antipsychotic and antidepressant, this is one of the common cases that we get in our clinic. Usually you have to be careful with them. Either you watch them if they have mild hyperprolactinemia. However, when they have symptomatic severe hyperprolactinemia, you may either reduce the dose or discontinue if possible with the psychiatrist, or you switch them to another drug that may have no effect on the prolactin level, or you may treat them with dopamine agonists, but you have to be very careful when treating them with dopamine agonists because that may lead to exacerbation of psychosis. So how to treat prolactinoma quickly? Just only quickly the natural history of prolactinomas. 93% of microprolactinoma usually do not progress to macroprolactinomas and over 4 to 6 years of observation. And the risk of progression is really over 10 years have been shown to be less than 7% or equal to 7%. And it has been shown also that people with microprolactinoma without treatment, 1/3 of them, they may revert to normal. And some tumor also may disappear spontaneously without treatment. And women with prolactin secreting microprolactinoma who become pregnant, they have even better outcome and better remission rate that can reach up to 14%. So the treatment will vary either from observation, medication, or surgery or radiotherapy, and that will depend on the circumstances, the symptoms, and the size of tumor, response to first line treatment, or any of the above. Only microadenoma with no symptoms can be observed. However, macroadenomas, they should be treated. And the most important and common treatment is dopamine agonist. And I don't have time to go over this all, but as you can see, dopamine agonist can result in really good response that can reach up to 100% in reverting the, or normalizing the hormones, as well as the shrinking of the tumor and reduce of the tumor size. And prolactin level may remain, however, high in up to 20% of patients with macroprolactinoma and 10% in people with microprolactinoma despite the treatment. And this is a list of the available dopamine agonists. Bromocriptine may be used daily, and cabergoline can be used once or twice weekly. Bromocriptine is one of the commonly used drugs. However, one has to keep in mind the inter-individual variability. Some patients may have an immediate response within 24 hours to 72 hours with CT changes within even 2 weeks. And some patients may have delayed effect with hormonal reduction in 6 weeks, others with radiological changes of up to 6 to 12 months. And continued tumor size also decrease may continue even beyond 1 year. The most important side effect, as you all know, nausea and vomiting and dizziness. And to reduce those side effects, it is recommended to start with the lowest possible dose and titrate the dose gradually. The average dose that we use is 7.5 up to 15, and usually doses up to 30 may be used in cases of dopamine resistant. Other side effects that may include the perivascular fibrosis of the macroadenoma and retroperitoneal fibrosis. Prolonged use up to 10 years have been shown to also be safe in some patients. And just want to introduce to you what I think most of you know about the bromocriptine resistance, which is caused by decrease in the number of dopamine receptors and defect in the post-transcriptional splicing. So this may occur in some patients. If it happens, then you may go to a doses that is beyond the usual dose, maybe up to 30 milligram. And you don't define this until the patient is on this dose for at least 6 months. If they don't respond, then we call them bromocriptine resistance. And it can take place or occur in up to 17%, and it is more common in men than women. The possible treatment approach for bromocriptine resistance is either you go up with the dose, as we mentioned, or you switch them to other dopamine agonists, or you subject them to other modalities of treatment. Switching from bromocriptine to cabergoline result in a good response in up to 70% of the cases. Cabergoline is a drug that can be used once or twice weekly, so it has better compliance, and studies have shown that it have even better tolerance, less side effect, and better outcome. So some authors recommend this, and guidelines recommend this as the first-line treatment for prolactinomas. Again, this is a dose. The average dose is up to 2 milligram that can be used once or twice weekly. Rarely, dose above 3.5 is required. However, in some resistant cases, you may go up to maybe 7 milligram. Side effects similar to bromocriptine, and however, there are some concern about the valvular regurgitation, especially with doses above 3 milligram. So recommendation is to do echocardiography regularly if your patient is on 2 milligram and above. This is the other dopamine agonist that may also be used with resistant cases. So this is an example of a tumor, micro and macroadenoma, and this is the same patients after medical treatment. So this is important. And we are remaining with some unresolved issue is, if we have time, we can discuss when to withdraw the treatment. Never keep the patient on treatment after 2 years or after the tumor vanish. Studies reports that anywhere up to 60% of patients will have normal prolactin in up to 2 years, and lifelong treatment may not be necessary. And this is a recommendation from the Endocrine Society for patients whom after 2 years of therapy have achieved normal prolactin level and no possible tumor remnant. They should be subjected to measurement of serum prolactin every 3 months for the first year, and then annually an MRI if prolactin increases. This is a Pituitary Society guidelines, suggest that to discontinue treatment if the prolactin normalizes and at least after 2 years of treatment, and should be followed up carefully. So surgical treatment is reserved for patients with mass effect and visual field defect on those who do not respond to medical treatment, and usually this is the approach, transsphenoidal surgery, and the response to surgery is really good for microadenoma as compared to macroadenoma. Craniotomy is not anymore required as before, and the side effect, as you all know, the operative side effect and include the diabetes insipidus and other pituitary hormonal deficiencies. Radiation therapy is reserved for people with huge tumor that they cannot be excised on, by surgery, or they have contraindication for surgery, and we have different modalities of radiotherapy. And the side effect may be delayed in up to 10 to 20 years after radiation therapy, and one have to keep this in mind. That include also the hormonal deficiencies. So this is summarizing the approach. If you have an MRI of the pituitary and it is normal, the patient has symptoms, or the patient has microadenoma with symptoms, then you start them on dopamine agonist therapy. If they have responded with normalization of prolactin, continue on treatment for at least 1 to 2 years with regular follow-up every 4 to 6 months. If they have partially responded to the dopamine agonist and they are asymptomatic, continue on the same treatment. However, if they are partially responding and they have symptoms persistent, or if they did not respond at all to dopamine agonist, you may consider surgery, but only after ruling out the resistant dopamine agonist resistance and titrating the dose or switching to other dopamine agonist. If it is macro adenoma, you should always assess the other hormonal function. And then you have to remember that if the prolactin is slightly elevated, that may be the stalk effect, or you have to rule out the hook effect that we have discussed about it earlier. If so, then you should refer the patient to surgery. If they have high prolactin, then you try dopamine agonist and follow same like what we do with the other prolactin, microprolactinoma. If they don't respond, then refer them to pituitary surgery. So in pregnancy, you have to be careful with pregnancy. We said don't measure serum prolactin. The outcome in pregnancy is better. The progression to micro and macroadenoma is less. They may have also changes within the tumor, with tumor vasculature changes. And this is the algorithm quickly. If patient get pregnant, you should stop whether microadenoma or macroadenoma, stop the dopamine agonist and assess the patient clinically for any symptoms of mass effect, headache, and visual field. If they don't have symptoms, then you just only follow them up. However, if they have symptoms of mass effect, then you do the MRI without contrast, and if there is any signs of enlarging tumor, then probably you may introduce again the dopamine agonist. And if they don't respond or they have apoplexy, then you should refer them to neurosurgery. Both bromocriptin and cabergoline have been proved to be safe during pregnancy. In menopause, again, menopause have beneficial effect in prolactinomas, and many recommendations do not recommend using treatment beyond menopause. Malignant prolactinoma is really a very rare disease with poor outcome. So I'll just end my talk in 1 minute with this case scenario. This is a 33-year-old woman with serum prolactin of 147, normal up to 15. She presented with regular menses and no galactoria or libido disturbances. She was on oral contraceptive pills that she stopped 2 years ago with failure to conceive. And she denied any drugs that may induce hyperprolactinemia. Transvaginal ultrasound and pituitary MRI were normal. So because of her regular menses, her serum prolactin again repeated, and again it was high, 112. So what do you think? What do you do next? So this patient, because of she does not have symptoms, her sample was subjected to the polyethylene glycol precipitation, and the repeated level came 7.2, which is within normal. All other investigation was normal. So how many of you will give this patient trial of dopamine agonist? Raise your hand. How many of you will investigate for other causes and don't give dopamine agonist? None? How many of you will refer to endocrinologists because they cannot? Okay. So the diagnosis of this patient, this is hyperprolactinemia due to macroprolactinemia. And no specific treatment or hyperprolactinemia, no treatment for the hyperprolactinemia is indicated. And the cause of this patient, high prolactin, is macroprolactin. So don't waste time by giving this patient dopamine agonist. She will not respond. You should investigate her for other causes of infertility. You should investigate the couples. So with that, I will conclude that saying that hyperprolactinemia is a common condition, and for the most important treatment for prolactinomas is dopamine agonist. And we are left with some of the unresolved issue. We hope that they get resolved in the near future. And with that, I would like to thank you, and sorry for keeping you late.